Good evening, everyone. On behalf of Eldorado BioTech Private Limited, I, Dr. Saili Shirkhedkar, Senior Medical Manager, welcome you all today for this evening. Today's topic of E-CME is diabetic neuropathy. As you all know that diabetic neuropathy is one of the serious and chronic complication of diabetes, and it has a stepwise clinical manifestation and diagnostic assessment. Hence, to know the diagnostic assessment, stepwise diagnostic assessment, and the preventive management, we need to look out for some of the clinical evidences and the clinical expertise. So for that, we have with us Dr. Mansi ma'am today. Welcome you, ma'am. I'll just brief you with a short introduction. Dr. Mansi Harale is a practicing diabetologist since decade from last 10 years in Pune. She has completed her M.B.B.S. M.D. From B.J. Medical College, and she has her vast experience in teaching as well as an associate professor in B.J. Medical College as well as D.Y. Patil Medical College. She has published her research and review articles in many of the national and international journals. At the same time, she has done her many certificate courses in her expertise of diabetes and thyroid disorders. So we are very fortunate to have you, ma'am, on this board for today's discussion. And then I think this topic of diabetic neuropathy to be heard from you is an honor for us. So I would like to request to start with your presentation. Over to you, ma'am. Thank you.
Thank you for the kind introduction. We'll start with our topic right away. So diabetic neuropathy is a vast topic. So we'll be covering a few parts of it, relating more to the peripheral neuropathy associated with diabetes and the treatment part of it. So this is how our agenda will be there. So there is definition of neuropathy, difference between nociceptive and neuropathic pain, statistics of diabetic polyneuropathy, the etiology and its risk factors, the pathophysiology, the classification, diagnostic evaluation tests, the screening scores, and management of neuropathy. Okay. I'll not put to the full screen then, we'll just see it like this. So yes, this was the flow of the presentation that I discussed. We'll do with definitions, we'll discuss the etiopathogenesis, we'll quickly classify, see about its evaluation tests and screening scores and how to manage. Okay, our focus will be on peripheral neuropathy associated with diabetes and its management. So nociceptive and neuropathic pain. So nociceptive pain is like post-operative pain, lower back pain, arthritis, meaning the pain is where the pathophysiology is. Neuropathic pain is different. The area supplied by that nerve is affected. So the nerve may be starting from elsewhere. It may be entrapped elsewhere, but the pain is through the root of the nerve. And that is why neuropathic pain is different as compared to nociceptive pain. So distal polyneuropathy, trigeminal neuralgia, central post-stroke pain. So in all these cases, the root where it is affected is different. Trigeminal neuralgia, the nerve is affected at its origin. Central post-stroke pain, so the lesion is somewhere in the thalamus, up in the cerebrum and surrounding area, and the pain is in the one side of the body. So that is why neuropathic pain is different. Statistics. So we'll just keep in mind what is clinically important. Diabetic polyneuropathy has been found between 26 to 31% in surveys in Indian patients. So it is quite a large number, and so everybody of us should be well equipped with knowing the pathophysiology, how to treat it, and what are the different kinds of presentations that our patients may come with. Etiology, the metabolic factors. So high glucose intolerance, so uncontrolled sugars, obviously long duration of diabetes. So even if the sugar is controlled, if the patient has it over a long period of time, the patient may have neuropathy. Dyslipidemia, neurovascular factors. Neurovascular factors leading to the damage of the blood vessels, that carry oxygens and nutrients to nerve. So less the blood supply, the more the nerve will be affected, and autoimmune and other factors which cause inflammation of the nerves. Hyperglycemia is the main pathological factor why the neuropathy develops. So here there is more glucose in the blood. So more glucose, what will happen to that glucose? It will make some products. Some of the products are called as advanced glycated end products. So advanced glycated end products, they hamper the protein kinase C, which is involved in phosphorylation. They increase the hexosaminase pathway. All these give to more reactive oxygen species, more oxidative stress, which damage the nerves. Also, when there is more glucose in the blood, aldose reductase enzyme will convert it into sorbitol. Sorbitol, it decreases the myoinositol, which is decrease in the nerve growth factor, contributing to the diabetic neuropathy. Also, NADPH is utilized in aldose reductase, so that causes decreased blood flow, decreased nitric oxide, and ischemic damage, leading to axonal loss and demyelination in the nerves. So all these things are related to the central core of hyperglycemia, which is diabetes. So the same figure shown in a different form over here. So hyperglycemia and glycemic variability causes increase in the polyol pathway that we just discussed, that is the sorbitol is increased, hampers the protein kinase C pathway, and increases the inflammation and the oxidative stress. Now we should look closely at this glycemic variability. What is glycemic variability? So our sugars should be maintained at a baseline. So when we eat, there is a little curve. When we don't eat, there is a little drop. So the highest curve where it hits above the baseline and lowest curve, that is the glycemic variability. Now, the more the glycemic variability, there are more episodes of hypoglycemia and hyperglycemia in the patient. So, the more the glycemic variability, the more the nerves are hampered. So, we should not only aim at good HbA1c, we should also aim at very less glycemic variability. Now, the same things in a different manner over here, you see toxic reactive oxygen intermediates are which are increased by every pathway which causes neuropathic pain. Now classify, how do we classify it? Now we classify it as generalized symmetrical, focal and asymmetrical, and a combination. So remember one thing, that the most common type of presentation, we have generalized symmetrical. So we have a glove and stocking kind which we know. So gloves is area covered till here and the stockings is the area covered till the below knee area. So this is how there is classical presentation of diabetes. So distal sensory or sensory motor neuropathy, small fiber neuropathy, autonomic neuropathy, large fiber sensory neuropathy. Focal and asymmetrical neuropathy, cranial, truncal, and limb mononeuropathy. So what is this cranial mononeuropathy? So the cranial nerves are affected. So they may be entrapped or they may be affected as a lobe. What is mononeuropathy? Any nerve, any thoracic nerve, cervical nerve, or truncal nerve or lumbar nerve, one at a time is affected, then that is a symmetrical or focal neuropathy. The patients may come to you in a manner that there is only one side of the truncal area where there is burning sensation. So that is focal neuropathy or mononeuropathy that the patient is suffering from. So we do this, but we then fail to realize that it is the same kind of mononeuropathy because we are so well versed with the diabetic sensory symmetrical polyneuropathy. Now, look at this figure very nicely. It is shown. I want you to look only at the upper part of the figure. So, what is large fiber neuropathy? The classical glove and stocking kind. The small fiber neuropathy, only the socks kind. There is proximal motor neuropathy. So, the thigh area is affected. It is the motor area which is very weak. So, we suddenly there are the quadriceps of this person become very weak. Truncal, I told you about neuropathies, that there is one area of the abdomen, then there is pain. You can have this third and sixth nerve, so only the um, uh, there is um, there is lateral rectus palsy. There can be eye involvement which is affected. There can be trigeminal neuralgia, and then there are entrapment syndromes. Entrapment meaning under the ligaments, these nerves are pressed. Now, this is median nerve affected, this is ulnar nerve affected, and there is lateral popliteal. So, this is under the radius, this is under the ulna, and this is under the fibula where the nerve is pressed. These are called as pressure palsies. So, we have all these kinds of neuropathies in diabetes. So this is basically a peripheral neuropathy that we are talking about. There are also other kinds which are autonomic neuropathy when the patient has severe constipation or severe loose motions. There can be cardiac autonomic neuropathy when the patient does not have any change in heart rate or blood pressure by normal variations that a person should have. So we are not going to discuss in detail about that. We'll stick to peripheral neuropathy. So yes, the differential diagnosis can be distal symmetrical polyneuropathy when there is burning feet, there are hyperesthesia, and there is nocturnal exacerbation, meaning at the night it worsens. Most of the neuropathies, diabetic neuropathies, are chronic sensory motor neuropathy. There is more sensations loss, or there are more sensory symptoms like tingling, numbness, burning sensation, and less weakness of the body. So we think that it is only sensory. So minor involvement of the distal muscles of the lower extremities. Small and large fiber neuropathy. Painless paresthesias begin at toes and feet. Impaired vibration and joint position sense. So now let us go back to our anatomy days and imagine that what is it that the posterior column carries. The posterior column of the spinal cord, it carries the vibration sense and the joint position sensation. This carrying of this vibration and joint position sensation, if it is affected, this will affect the balance. So large fiber neuropathy which travel through this posterior column affect our balance and thereby may cause ataxia. Similarly, a small fiber neuropathy causes just like this distal symmetrical polyneuropathy, burning, allodynia to light touch, that is paresthesia. So this is how they present. We have to know it all. Nothing exists alone. There can be overlap within these also. And then what happens? We have all heard about Charcot joints. So there is less blood supply over there, less nerve supply over there. So the joints, they do not feel any pain, and they actually are deformed joints without any pain. That is called as Charcot joints. And Charcot joint patients may have foot ulcers, autonomic impairment, and small joints of feet are affected, and thereby they don't have the exact arch that the feet should have, and thereby have foot ulcers. Acrodystrophic neuropathy is distal joint destruction and chronic foot ulceration. So the same kind. And pseudotabes, as I told you, the posterior column, the nerves coming to it may be affected, thus causing posterior column affection, which people may call as SACD or tabes dorsalis, but it is diabetic pseudotapes. This may also have diabetic pupillary abnormalities like pseudo Argel Robertson pupils. So they do not coincide with the contraction, and expansion of the pupils. I discussed about diabetic autonomic neuropathies relating to the GI and the cardiovascular autonomic neuropathy, which is also called as CAN. Now, if we were to compare between mononeuropathy, entrapment syndromes, and distal symmetric polyneuropathy, all of which are present in diabetes, how we would. So, what are the nerves involved in mononeuropathy? As I told you, the cranial nerves 3, 4, 7 can be involved, and those nerves under the bones, that is the ulnar nerve, medial nerve, and peroneal nerve, can be involved. In entrapment syndromes, those nerves again, the ulnar, median, and peroneal, medial and lateral plantar nerve can be involved. And in distal symmetric polyneuropathy, it can be motor, it can be sensory, it can be autonomic, or it may be mixed. Now, treatment is symptomatic for mononeuropathy. For entrapment syndrome, there are rest, splints, local steroids, diuretics, and surgery. So, entrapment syndrome, which we all are very commonly aware of, is carpal tunnel syndrome, seen in many women over 40 years of age. So, we give them splints, insert some steroid, and otherwise, if take physiotherapy, and if it is not working, then we perform a surgery just to release that tendon. And what about distal symmetric polyneuropathy? We tried tight glycemic control, that is, control the sugar levels. And then there are pregabalin, duloxetine, antioxidants, Nutrinerve, and research drugs. So what we will stick to is tight glycemic control and some anti-epileptic drugs. Distribution of sensory loss is in a classical glove and stocking manner in the distal symmetric polyneuropathy. It is beyond the site of entrapment. So if it is entrapped over here, then the carpal tunnel syndrome will have beyond it. Here, it will be affected, the sensations. And it is not sensory loss, it is actually tingling and numbness, which is perceived. And in mononeuropathy, it is actually where the nerve is supplying. So how do we approach to our case? We assess symptoms, we assess the clinical sign, and confirm the pattern of signs and symptoms. We don't need to have a straight diagnosis that this is mononeuropathy and not polyneuropathy. This is motor neuropathy and autonomic neuropathy, because everything can coexist together. What do? We do the same tests that we have done for all our patients. We do a urine analysis for protein and for glucose. We do a HbA1c, the creatinine, and the electrolytes, the liver function test, the thyroid function test, the vitamin B12 levels, serum protein electrophoresis. In some patients, we are expecting multiple myeloma, and assess symptoms for weakness, cramps, prickling, numbness, or pain. Of course, we do that. We ask patients. And X-ray, if it is entrapment syndrome, is what we are suspecting. Now, scores and sign. So we should know that we are going to actually see what is the score, and then think should we include this as neuropathy or not. But this, let me tell you, is only very theoretical, or if you want to make a thesis, or if you are really concerned that this is not neuropathy. So we will be seeing the NDS, where the maximum score is 10 and 6 or more is predictive of foot ulcer risk. So here we are, the NDS, the Modified Neuropathic Disability Score. So we have the right side, we have to mark differently, and left side, we have to mark it differently. This is the tuning fork that we use, the classical tuning fork, which is of 128 Hertz. You use in the OPD to actually see till where the patient has sensory loss. So if it is abnormally low somewhere, you mark it as 1. If it is normal, you mark it as 0. So here you mark it. Temperature perception. So we did vibration, now we are doing temperature. So we did this tuning fork only in ice cold water or very hot water and touch it. Pinprick. So pinprick just enough to deform the skin. So can he feel it or he not feel it? If he cannot feel it, it is 1. If he can feel it, it is 0. Actually, is reflex. So we do a ankle jerk, and if it is present, present with reinforcement, and absent. So 0, 1, and 2. So for both limbs. So the highest marks everywhere can be 1, 1, 1, 1, and 2 over here. So it is 5 on each side, that is 10. So total score out of 10, to calculate anything over 6, patient is a foot ulcer risk. He will need a good footwear to wear. He'll need to wear footwear at all points of time. And he'll need all the care that we can give. Now, what are the other things that you can do except this M.B.B.S score, where we used vibration sensation? We used the ankle jerk. We used the tuning fork to see the sensations also, hot and cold. Okay, so and the pinprick. So when we used all these, we can use something else also. There is something which is called as monofilament, which gives only 10 gram of pressure. If it is perceived, it is normal. If it is not perceived, it is not normal. Then there is tuning fork, wherein there is visual optical illusion to determine the intensity of residual vibration on 0 to 8 scale to the point of threshold. Same like tuning fork. Tactile circumferential discriminator. So I want you to remember that during our first year, when we had 2-point discrimination. So 2-point discrimination, that is what we are going to see over here. And neuropen, just the filament should not be held with hand. There is a neurotip which the patient may perceive or not perceive, and there is a filament which the same neuropen carries. So we can do 2 tests at the same time. So these are the devices and these are the tools that we used for screening the neuropathy. Electrophysiology, yes, we conduct a nerve conduction study. So nerve conduction study is only gradually diminished by diabetic polyneuropathy, which estimates a loss of 0.5 meter per second per year. So it is related, though it feels like a small figure over here. There is a loss of sensation from distal to proximal. That is what they are saying. And both of them are affected, the SNAP and the CMAP. SNAP is sensory nerve action potential and compound motor action potential. So the total area of SNAP and CMAP suggested as a means of assessing contribution of slower conducting fibers. So everything is reducing if we quantify it. Okay, so make things better. We don't, sometimes they are reversible, sometimes they are not reversible. We should be able to recognize and at least give the treatment that is required at that point of time. What are the management options? So what are the strategies? What all of us know is the glucose control mechanisms and lifestyle modification. This will control our blood sugar levels. Pain management, so symptomatic management, anticonvulsants and tricyclic antidepressants and other agents. All these we are going to use. This is one of the most standard treatment algorithm that we have to know. There is painful neuropathy. What do we use? We consider contraindications to this drugs and comorbidities if the patient has, and if it is not contraindicated, we use. What are the things that we use? We use pregabalin or gabapentin. We use tricyclic antidepressants. We use SNRIs, selective reuptake inhibitors. So no clinical meaningful effect, then combine them. So what we do, pregabalin with TCA or gabapentin with TCA, SNRI with TCA or SNRI with pregabalin. So what we do is combine them to make it effective, or we increase the dose whatever we can to the maximum without causing side effects. So try combining agents from above, switch to another agents, or may add tramadol or tapentadol if everything fails. So this is what we have. We have three options: pregabalin or gabapentin, TCA and SNRI. And if they fail, increase their dose, combine, and add tramadol. It's the same thing over here, only in a slightly different fashion. We have to know that after the first figure that we saw, the last slide that we saw, we have intrathecal drug delivery system. So if nothing of it works, go for an intrathecal drug delivery. Intrathecal means spine mein there is needle which is good, the catheter which stage, and we keep on injecting the patient with drugs um, that will bring down the pain. And then there is paracetamol that we can use. We can use physiotherapy and acupuncture, which will help the patient to bring down the pain. This works more in entrapment neuropathies. So yes, the same things discussed again. Tight glucose control can reverse the changes only if the neuropathy and the diabetes is recent in onset. Tricyclic antidepressant, amitriptyline and nortriptyline are used. Anti-epileptic drugs, gabapentin and pregabalin are used. And methylcobalamin, which is vitamin B12, it exerts neuroprotective effects and regenerates the myelin sheath. So this is what we are used. Tight glucose control and methylcobalamin, I think we should use in all. And then think about where we can use what in all patients. So glucose control strategies, evidences from studies. So there was this bypass angioplasty revascularization investigation 2 diabetes trial, in which participants treated with insulin sensitizers had a lower incidence of DSPN, that is diabetic symmetrical polyneuropathy, over 4 years than those treated with insulin or sulfonylureas. Now, why? Because insulin and sulfonylureas will have more glycemic variability than the other insulin sensitizers. Okay, and that is why more diabetic neuropathy in those with insulin and sulfonylureas. Lifestyle modification, that is exercise and diet. So low fat diets and exercise, which is alone or supervised at least half an hour per day, that is 150 minutes per week. So this is very common and age-old practice, which we should not leave aside even for neuropathic pain or neuropathic symptoms. Pain management, pregabalin and diloxetin have a regulatory approval for treatment of PSPN pain, and the opioid tapentadol has regulatory approval in the United States and Canada. So what they are saying, pregabalin and diloxetin is what you should use for the pain of neuropathy, and the opioid can also be used if the above agents fail. The anticonvulsants, the same drugs, pregabalin. Pregabalin is a calcium channel alpha 2 delta subunit ligand and is effective for neuropathic pain. So what happens? Pregabalin, if compared to gabapentin, has linear and dose proportional absorption, and that is why when compared with gabapentin, pregabalin is something which is more easier to use. Now here, if we see, pregabalin binds with high affinity to alpha-2 delta site. What it does actually is it reduces the calcium-dependent release of glutamate and substance P. Glutamate and substance P are something which are going to bring about pain. Okay, so it stops the release or reduces the release of this glutamate and substance P. And something which is a good agent, it increases those levels. So it increases the GABA levels, decreases glutamate and substance P, and it reduces the neuropathic pain, and also it is anti-anxiety. So what are the indications for which we can use pregabalin except the diabetic neuropathy and pain of the diabetic neuropathy? is management of post-herpetic neuralgia. So after herpes zoster, the patient may have neuralgia for a long period of time, where we can use adjunctive therapy for adult patients with partial onset seizures. Yes, it is an anti-epileptic. And management of fibromyalgia. If nothing works, we can use this. So, pregabalin has 140 clinical studies and 20 studies are there only in diabetic polyneuropathy. Daily dose of pregabalin can be divided doses 2 times a day or 3 times a day. It decreases the pain scores. It has a superior profile in terms of efficacy and safety. Now, this was pregabalin for the treatment of painful diabetic polyneuropathy. So, 146 patients were randomizedly given pregabalin or placebo, and the duration was 8 weeks. So, the 11-point numerical pain rating scale was used for them to give the points of about how much the pain is. Now, if you see over here, this is the pregabalin arm and this is the placebo arm. You see over here, there is a reduction in the pain scores in pregabalin arm as compared to the placebo arm. So that is why we see that pregabalin is important. As to compare it with gabapentin, it has no known drug and drug interactions, whereas gabapentin, there is decrease in the bioavailability if an antacid is used. The dosage can be 2 times a day or even 1 time a day. SR preparations are available in 150 and 300. And overall pharmacokinetic actions, it is more stable as compared to gabapentin. Now we come to tricyclic antidepressants, that is amitriptyline and nortriptyline. Now they block adrenaline and serotonin uptake, augment descending noradrenergic and serotonergic inhibitory pathways, block sodium channels, analgesic effect independent of antidepressant effect. Yes, TCAs are antidepressants. The name has antidepressants, but even if they do not, the patient is depressed or not depressed, they act. Now, here are the two arms. Now, these are not depressed patients and these are depressed patients. Now, this is the placebo arm and this is the amitriptyline arm. Now, you see the pain intensity has reduced in patients with those on amitriptyline in both the arms as compared to the placebo arm, and it is in both not depressed and depressed patients. So compared with placebo, amitriptyline reduced pain to a similar extent whether the patients were depressed or not depressed. Methylcobalamin, so the third drug, paresthesia, burning pain, these are relieved by methylcobalamin or at least decreased. It increases the synthesis of lecithin, major component of myelin sheath, regenerates myelin sheath, thus protecting axons and peripheral nerves. So that is why it is neuroprotective, and that is why methylcobalamin is also used. What are the clinical evidences that we have? We have the active form of vitamin B12. It acts as a cofactor for methionine synthesis. 7 randomized controlled trials are there, and it has beneficial effects on somatic symptoms like pain and paresthesia. It improves autonomic symptoms and leads to symptomatic relief. So there was Beijing Methcoban clinical trial collaborative group, which found that there is 73% improvement in spontaneous pain, 75% improvement in numbness of limbs, and this autonomic symptoms like hotness, coldness, oral dryness, dysuria have better response than the control groups. Methylcobalamin is a safe agent in the treatment of DPN. DPN, diabetic polyneuropathy, is multifactorial neuropathy, the most common complication and the greatest source of morbidity and mortality, because it may further lead to foot ulcer formation and then gangrene and then death. Stringent glucose control mechanisms with perfect use of above discussed agents can be best line of treatment. We can even give pregabalin with amitriptyline and with methylcobalamin all together in good dosage to decrease the symptoms. So thank you. That is the end of my session. If there are any questions, I would like to answer.
Thanks a lot for this wonderful discussion, ma'am. I think stepwise assessment and properly diagnostic would be a better preventive management, I think, for early detection of this diabetic neuropathy. Any questions from audience? Ma'am, I have one question. Earlier also, we had discussion on these topics with some of the team. So one question, again, persistently keep in mind that as you have told that many a times this diabetic peripheral neuropathy is bilateral and symmetric specifically to the lower limbs, that what we called stocking and glove one. So I just wanted to know that whether in case of the person is diabetic or non-diabetic, how should it be prevented in early stages?
Yes, for diabetics, I can tell you. For diabetics, we have to have good sugar control, and that comes with diet, exercise, and the medication. So we should try and get the HbA1c to normal or under 7 by hitting hard early. Okay. So if need be, we can use insulin also and get it to normal. So this will prevent the neurovascular factors contributing to the neuropathy, and thus will prevent the neuropathy altogether. And at least whatever it comes with the duration of diabetes, it may come later, but at least in the first part of it, we may be preventing. Also, secondly, there are patients of cervical spondylosis which may have these symptoms later. We may have lumbar spondylosis who are like they have difficulty in walking from years altogether. So whenever such a patient walks to you out of reason which is beyond the cervical spondylosis or the lumbar spondylosis, we should still make it a point to see that yes, how many days are you suffering from? Why don't you get a MRI done? And then we can go forward, and if need be, the ortho people can intervene and take off the pressure of that nerve root so that the neuropathy can be prevented. We can also, if patients are not willing for MRI, we can also suggest physiotherapy or small practices like not using a pillow or using a roll of towel if need be, using a non-rotating chair. Having neck exercises every day. This also will prevent neuropathy. For vegetarians, B12 supplementation at least 3 months in a year, that also helps.
Yes, yes, that's true. That's true. Ma'am, I would like to also ask one question that presence of this diabetic peripheral neuropathy, specifically in the geriatric patients, many a times it leads to sensational loss and some disturbances in the gait performance as well. So for that, will the treatment option, what you told about this management can be a good or a certain different line of therapy also we have to add with this complication?
Of course, whatever I told is okay, but then if we are seriously suspecting that I have given 1 month of B12 therapy and the patient is still not improving, I should go for vitamin B12 levels testing of that patient. If it is too low, I should be giving him injectables for the therapy. If the gait is still not improving, that means he has already, it is something which is not going to improve. So I should give him a footwear which is customized for his feet so that his arches of the feet are not lost, and thereby calluses are prevented. Because the calluses are prevented, the ulcers are prevented. Because ulcers are prevented, the whole thing with the infection of the ulcers and leading to the amputation of the limb, everything can be prevented. So both for neuropathic and ischemic ulcers, all can be prevented.
So the combination of non-pharmacological treatment and the pharmacological treatment, I think, can be a better option for this manifestation. Also, ma'am, I have one question that nowadays gastrointestinal neuropathies are also trending and prevalent, as you have told in your slides as well. So what should be the early sign or any symptom to just get it through, whether it is a type of neuropathy, gastrointestinal neuropathy, or normal, some different gastrointestinal disorder or something. So I think gastroparesis or early emptying time, what should be the exact line of diagnosis?
I think it is more than having a blanket definition or this how we can do it. We have to be a patient-based thing. So any disease which is going to have neuropathy can have these things is what you should know. May it be diabetes, may it be something else. So if it is diabetes, I know this person is not only going to have peripheral neuropathy, but he may have gastrointestinal symptoms also, and he can have cardiac symptoms also. He may not be able to tell me if where he got hurt. He may not be able to tell me even if he has a heart attack. So the chest pain may also not be evident. Similarly, if the patient says there is bloating in my abdomen, that also points to gastroparesis. If the patient says I am emptying my bowel 3 to 4 times a day after I have every meal, that also points to the autonomic neuropathy that the patient has. Sometimes we cannot even improve any symptoms. We have to just counsel patient that this is a part of your disease. This can be regulated if you have less spicy food, or you may have decrease in the frequency, but you may not be able to stop it altogether. Similarly, we can improve the consistency of the stools with the help of the isabgula husk, that by giving the patient, so they have a feeling that I am passing semi-solid stool, so the condition has improved. Second, we have to add prokinetic agents to their antacids so that they have no bloating in the abdomen, so that they also feel the hunger. They are also able to eat well, though with a less calorie intake, they will eat well. So we should be aware of all these things, and then only we will be able to have empathy towards our patients and treat every single thing that they complain of.
Right. Ma'am, we have a question from audience. One of our doctor want to know the standard dosing of pregabalin along with TCAs, amitriptyline.
Can you repeat the question?
Standard dosing of combination of pregabalin and amitriptyline.
No, there is pregabalin and nortriptyline, which are used in combination. But yes, pregabalin and amitriptyline can be given differently. Pregabalin can be started with 75 mg, and then we can increase it to 300 mg per day. In SR preparation, 150 mg SR and 300 mg SR preparations are available, which work for once a day. Similarly, amitriptyline, we can give start from doses of 10 mg, we can escalate to up to 50 mg. So we have 10, we have 25 power, we have 10 powers available, we can use it like that. Okay. So also think that these have side effects, these have effects. So we have to increase it very slowly over a period of weeks. We cannot increase it. We cannot give it all at one go, because then the patient will stop eating the tablet and then stop coming to you.
So gradual titrations, I think, is a key for perfect management. May it be in ascending in case of start of treatment and descending in case of lowering of the symptoms. Right. So any questions from doctors? Yeah, I think there is no any questions from the audience doctors. So I think this discussion was pretty cool, very easy to understand. And I think the diagnostic approach was very well explained by ma'am. And I think it will be very beneficial for all of us to have practice in our clinical practices as well as. And also the clinical evidences which were given was completely correlating with what prevalence we see in our patients. So I think this is a wonderful discussion on diabetic neuropathy. And I think more such discussion should be there because it's a very vast topic, and pinpoint points also takes a lot discussion of 1 to 2 hours for this specifically complication. So I think I thank you all, everyone, for participating in this CME. And I thank you, Dr. Mansi, for sharing your wonderful insights and the clinical expertise. And I think this will be very beneficial for our doctors and the audience to implement in their clinical practices. On this note, I again thank you all on behalf of Eldorado BioTech, and I expect such more meetings in future. Thanks a lot, everyone.